We'll open up, we have about a half hour, I think, at the moment to open up for questions and comments from the roundtable. And I want to start with one. I'll take the prerogative of taking the first one, specifically to Ariella. You had great data on improvement, as a matter of fact, subsequent to intervention, which is a great way to do quality, really using the PDSA cycle. I was wondering if you had data on childhood immunization being an important aspect of what you do.
Not yet, but it will come.
Okay, just want to put that on the radar screen. Okay, well, please identify yourself as you come to the microphone. Cindy?
I'm Cindy Brock with the Agency for Healthcare Research and Quality's Center for Delivery, Organization, and Markets. And my question's for Katina. First of all, actually, let me say it is a real testament to what a terrific panel this was, that we are all lining up to ask you questions. That's a real compliment, because very often there's that awkward pause where you're waiting for people to and you were all so stimulating that we raced to the microphone. So thank you. Katina, you'd said that your goal was really to meet the community needs. And you said, we have some things we know that work. So you were kind of trying to match those things to what the community needed. And I was wondering, given what we heard this morning about the status of the research, what criteria did you use to decide what works, what you were going to include in your toolkits, and what did you do if a community said, well, we have this need, and there wasn't an evidence-based intervention?
Thank you. That's a great question. So what we say works really came from our work with the Coalition for several years. And so when we think about what works for them, we know that they have materials and resources that they're using that they don't feel good about, that they don't feel are accessible to folks. We know that we can help them with the language and the quality and get them to a different standard. We hear over and over again that people are having trouble with understanding health insurance and making choices. We have a lot of information from the Sisters Navigators. We have data about what kinds of trainings and programs can help people change their knowledge, skills, attitudes about those things. Behavior is tricky because the behavior to enroll is contingent upon all these other things, not just that you want to enroll. But we know that we can help people get to the point that they can make the best decision for themselves and their family. And we have trainings to help people do that. We know how to change that information for them. We know from the data that Teach Back is really useful in lots of places, and if we go out into the world and we have the chance to tell anybody about how to help assess messaging and verbal communication in communities, we want to do that. So all of those things that are sort of the bread and butter of health literacy that have the level of evidence that we all sort of agree are helpful, not harmful strategies we offer again and again. We also have a training menu across all of our partners in the community. So anybody who's been on the Cover Missouri Coalition Technical Assistance Group has a series of trainings that have been vetted and approved by the foundation and other folks based on sort of the evidence. And all of those things are available to the community. So again, I used the example earlier of people want to talk about what happens when a reporter calls me for a quote on health insurance. I don't feel comfortable being on the news. We can take the folks from Fleischman-Hillard and teach people how to actually give an interview that they feel comfortable with, so they can be on the news media for themselves, and they don't have to call us in from St. Louis to be the sort of talking head for them. So all of those kinds of things we've done over and over again through the coalition, and we've measured people's satisfaction and success and how that works. And we've used those as interventions that we know work. But it's loose, right? So if you compare it to the standard that we set this morning of, sort of what interventions have efficacy and work, I'm not sure that it would reach the same level.
And then the second part, if somebody, expressed a need that you didn't feel like you had something that worked for them, what do you do?
So we've got, 25 people sitting in the office that are smart and have degrees and learned how to go and find and get and use information and figure out how to put it together in an accessible way for the appropriate audience, and we make it for them, and then we ask them what they think, and we really work hard to make sure that we use health literacy strategies to make sure that we've hit the audience right and the purpose, and that we know what we're trying to say, and that we don't make up messages. We get them from the evidence across the board, and we're lucky. I mean, we live in a city with a couple of graduate programs with really smart folks that do internships with us, and so if we have something really hard, we can get an intern and assign them a project, and they create it and get a grade. And these things happen all the time, and they make sort of beautiful working interventions.
Michael?
I'm Michael Apasciolo, Boston University. So thank you very much for presenting your work, and some of you, this is really, your life's work at this point, and it's very impressive to see reach and touching lots of people. One thing that I noticed, Marissa, you used a word that I think nobody else used, and you used it 3 times, and I want to see if we can use this to stimulate you guys to tell us something that may be happening here. Community-based work is sometimes more part of society, if you will, than some other types of work. And 3 times Marissa said the word determinant, right? So is health literacy a social determinant from your perspective?
Well, when we developed our position statement, we were looking at, again, the different sectors of our community. So when we were looking at the connection of education and health, we kind of started out that direction, but then it quickly, again, because of our stakeholders, our content experts, I mean, literacy is the fundamental level of what we want to address. And so health literacy kind of was the direction we went. And again, literacy is the determinant that I'm focusing on when I talk about health literacy. Is that?
So, Michael, can I answer that question? Yes?
Well, so that's fine if you do. I don't know if there's other comments. I've noticed that none of the state efforts to measure social determinants include health literacy as one of the items that they use, either for risk adjustment in their Medicare programs or in any other function that they're using these programs. This group has discussed multiple times, is it a derivative of social determinants, or is it itself a social determinant, independent of others? Bernie just went on the record saying yes. I'm very proud of him. He hasn't come out about that before. Anyone else?
So I'm a social worker, and when you say that, I start to think, okay, let's talk about what health literacy is, and I start to think about all the components of the pieces of information and personal characteristics that make health literacy a factor or not, and it makes me itch a little bit to say that, like, in and of itself, it's the one. So I think it's important. I think it's a cross-cutting theme. I think that there's a lot of conversation about really what are the core characteristics of what is the social determinant. It
has to be one. It could be
I don't know.
Most of these state programs measure 15 things.
I hear you.
Or more, but don't measure health literacy.
Well, so I'm not saying not measure it, but if you think about it as is health literacy a social determinant? Like, maybe, but there are lots of pieces of what it is too. So, this gets back to what do we mean by health literacy? You're always provocative. That's pushing. You want to throw something too?
I would say yes. I think it is. But I think we have the problem of the measurement. To make it part, we should all agree on how are we going to measure it, and this is where I stumble.
So that may be 2 different questions. A, is it a social determinant, and B, how do you measure it? But that's for another roundtable. But I think it's a very good discussion. Just to avoid disappointment, I think we have enough people at the microphone. I can handle all, but I don't think I can handle any others. So just let's stick with it for the moment and just see where we go. Terry?
Terry Davis, LSU Health Sciences Center, Shreveport. So, Ariella, you have a lot to teach all of us. I know you always teach me. And so this is a assessment question. One of my challenges is how you write a 1-page assessment that people can understand and independently respond to. And can you just talk about that a minute? I mean, we get going on assessments and all of a sudden we got 25 questions or something. So tell me that story.
Well, it took multiple rounds. And since we were present when the families were filling the surveys and we would get totally blank answers, we had focus groups afterwards to try and understand why were the answer blank. And the majority of the answers were that they didn't understand the questions. So we did a second round and a third. It took us 5 years to get to this. It's 1 page on 2 sides. Huh? Let me be and we did focus group across the country to see if it wasn't related to an ethnicity or location. And then even when it was simplified and translated in other languages, we had other hurdles because Spanish is not the same for everyone. And so this is, I wouldn't say we're perfect. I think we're making progress.
I think it's challenging to get the information you think you need as a researcher or evaluator, but be able to give something that people find useful and understandable.
Yeah.
Very challenging.
Yeah.
Andrew?
Thanks, Bernie. I'm Andrew Pleasant, and if you're wondering, I have been to Oklahoma. So each of you work in sort of an administrative, academic, regulatory home with all of those straight lines and little boxes and requirements, but you've managed to somehow embrace the lovely messiness of community. And I know that there are a lot of people across the country in cities and states and neighborhoods and regions that are trying to create coalitions and umbrellas like you have. So what would be your one best bit of advice for people like New Mexico and Colorado, and the list goes on and on, that are right in the very nascent stages of trying to do what you've succeeded at?
I'd like to say that I think being involved, and it requires being involved way more than just your job, being involved in your community where you're actually going on behalf of you as a citizen of the community to say something in front of them, and actually integrating the things that you're doing on the job into what you personally believe and want to see improved upon. And that goes into your volunteering and being a part of a civic organization or your professional association. I mean, those that have been involved in our efforts have been those people that are movers and shakers. A lot of times we say those are the same people that are at every table, but those are the people that are really doing things, and we're seeing more people like them that they're mentoring that they're bringing to the table too, and those are those individuals that we need to be involved to make things happen. I mean, you got to go beyond just your work to share the message in a lot of different ways that relates to those people that you're encountering on a daily basis.
Yes.
Turkia Gardner from Pragmatica. As I was listening, I was very illuminated and enlightened. However, I took some notes that I'd like to repeat, which might be useful for others. When I heard Dr. Herman speak, she said, relative to feedback, she said, we share using their own data. And being a statistician, that really was very highlighting. Then she also said, we use materials they can use and understand. And that was illuminating too, and that brought back another roundtable, which I contributed to here in the Academies, where somebody from Weill Cornell Medical College involved in communications said that there are differences in the way people understand percentages and fractions. For example, if you ask the question, what is 50%, they'll answer about half. What is 70%? Yeah, about half. What is 30%? About half. What is 95%? Oh, that's just about everything. So there are differences in perception and comprehensibility. And that ties in with the very highly highlighted personalized medicine that we hear. bring it down to the personalized level with all the data that we have, with all the different alternatives that we have. Now to my question. I heard about the Head Start program some years back relative to school-age children, but I heard mentioned emergency medicine and primary care. How does all that relate to what was presented relative to comprehensibility and the Head Start program? That's my question. Thank you.
Thank you for taking the notes. I think you highlighted some important elements of my message. Head Start serves children and families, children 0 to 5, and it starts at pregnancy. And what we found out is that these parents care for their children and they want to do the best they can. And when they don't know if the child is hot or too hot or not hot enough, they run to the emergency room. And this is why we introduce over time tools, hands-on, distributing thermometers, teaching them how to use them and what to do first instead of rushing to the emergency room. The same as the difference between a teaspoon and a tablespoon. You can very easily overdose a child or a toddler, and a lot end up in the emergency room. So that's the change in behavior that we tried to do. Not that they never have to go, but it shouldn't be the first source of help.
Wilma?
Wilma Alvarado Little, Roundtable member. So thank you very much. The energy that all of you Shiros presented has been awesome. And Ernestine, what a great job in presenting the facilitation and the questions. So unlike my colleague here, Michael Pasciarlo, I didn't count the number of times folks use words. However, what I did do was, my little ears always perk up when I hear things, saying languages other than English. And so I was very pleased to hear that. So my question, because y'all know I asked this, is what considerations were made for our communities whose members are either deaf and hard of hearing or need other needs or considerations, and at any level, whether it be a participant, a parent, the child. And then my second question is to Ariella. So say, for example, I've participated in this fabulous work with my child in a Head Start program. And we're at an age where it is so important to begin to plant and nurture those seeds. Yes. So now as my child progresses into the next phase of their education, in my mind, because I've been exposed to this fabulous work, I'm now expecting it at other levels. So what partnerships or considerations, if you will, have been made to help me understand that this is a process that I may not be blessed in experiencing again, or maybe I will?
We have given a lot of thought to your question. And what we are trying to achieve is a gaining confidence for these families that given the right kind of health information, they can understand it and use it. Unfortunately, we did not track these families beyond Head Start, where they find themselves in the public school without this kind of information. But we did see that a big percentage of these families became part of the policy council, became stronger advocates for their children. So for us, it is a start at a moment where parents are the most open to learn and to get the tools, but by no means do we provide a lifetime of tools.
Can I respond to that too? I happen to wear many hats, and one of the hats is being a chair of a Head Start board that's across the country. And in that, I do think many of the models that we're working on we have partnerships with the school districts, and with the newer performance standards, I think you're going to see more in the future of tracking into the public secondary school setting. Would you agree, Ariella? Yeah.
Lindsay?
Yes, hi. My name is Lindsay Robinson. I'm from the American Dental Association, and I'm a pediatric dentist. And actually, Wilma asked one of the questions that I had about that, about Head Start, and beyond Head Start, what happens to the families? I wanted to preface my other question, though, by just saying thank you to the panel for looking at different aspects of community and how communities can be enriched and touched in so many different ways. And thank you to Katina and Ariella for having an emphasis on oral health, especially around visits to the emergency room related to dental disease. And that's, I think, a reflection of the unmet need in communities for dental care and for preventive services. And it's reflected in having to go to the emergency room. And there are lots of different reasons for that. One of the primary reasons is the lack of dental benefits, both on the commercial side and on the government-funded side, because so many states, most states, don't have government-funded dental benefits for adults. And so adults so often end up in the emergency department to deal with infection and pain that could have easily been taken care of earlier on before it got to that point. So I wanted to ask about, well, your outcomes area that you presented are so impressive, and the interventions that you've done have made a huge impact for children. How do you know, have you been able to measure the impact on the families as a whole and the communities as a whole? Do you know what impact you've had? Because I am I do Head Start visits, I do screenings and exams and health promotion to 2 sites in my community, and I try to do it when I've got caregivers, primarily the mothers, there, so I'm not just looking at the child and then filling out a form and leaving, and I can actually have a conversation with the mom, with the caregiver, look in her mouth, give her some information about her own oral health, and then if necessary, if she needs to get connected to care somewhere in the community, we can navigate her and get her into the right place. So have you been able to do any measuring of what the community impact has been?
So for oral health, when we do our prevention module, it's really geared towards parents first, starting in pregnancy, and then applied to children, because we believe that that's what it needs to start. We did not get to measuring the impact in the community. We did measure the impact in the community for our Eat Healthy, Stay Active module, where we really, first of all, measured the impact on families, knowledge, behavior, and weight, but also these families going into the community and really make changes on what needs to happen, demanding, being much more activated. So you're making a very good point. We're not done with the data collection. That's a process, and we'll continue.
Jim?
Hi, I'm Jim Doss from the Health Resources and Service Administration, and also a member of the Roundtable. This question's for Katina and anyone who else would like to answer. I'm interested in knowing if you had the opportunity to observe the communities sort of acting on their own initiative to teach others and sort of diffuse the innovation without the so-called experts in the room.
So it's interesting because of the coalition relationships. We have been in these communities, or we've been related to these communities for several years, not providing services. So we don't have metrics for it because we didn't know who they were, so we couldn't collect all of that. But we were able to sort of watch them and think about it. And that's how we got to the point of picking the 4 communities that we selected. We wanted to make sure that we had communities that were already high resource, that the foundation had been there a lot, some other communities that really hadn't had many resources at all other than sort of their own initiative. And we wanted to be able to compare those and look at what decisions they made, what their paths were, how they sort of processed through this, knowing that we know a little bit, we're informed. We basically were doing an informed intervention. It was not blank at all. But we did not go in and monitor without intervening for any period of time in advance. So that would be fun, but we didn't get to do it.
I would like to add something to your question. We have just done a survey with Head Start families and got about 1,000 answers. And one of the things that was striking is that they all said that they have become the center of information in their neighborhood, and that they go and talk in churches and show the resources, and that many people come towards them to get the information. So that's, I believe, a first step in expanding it.
Jay?
Hi, Jay Duig, member of the Roundtable with AbbVie Patient Safety. Again, to complement all of your programs and driving from concept and idea to actually impact on the community. That's never easy and always worth celebrating. What's the greatest opportunity that you would see for web-based interventions on community health literacy? Because while the virtual communities may be outside the scope of our discussion today, and please challenge any of this, I would say that web access, while not universal, is certainly increasing with smartphones across all communities. And we are hopefully approaching a point where we understand that just because you put something on the web or that there's an app for it, that does not equate towards solution or impact. So I think we think about intertwining and having complementary web-based resources or programs to intervene on some of your issues. What would be your experiences, and we think about best practices? I'll really open that to anybody. Katina, I'm most familiar with your work, so not to put you on the spot, but to any of the panelists.
I'll start, and I'll just say, the interesting thing about it is most of the issues that sort of bubbled up from our communities were issues that involved sort of being physical. So eating, exercising, moving, going to the doctor. So you can provide the education through the web, but the actual activity that we need people to do is sort of real time. And for many of the folks, these are things that we heard somebody say this morning, something about, we all know that we're supposed to do these things, but we sort of don't want to because we don't like the food and it's hard. So this idea of how to move people to action on things that they don't want to do because they're hard and we're not ready for them, and a diet's not fun or an exercise class is not until you start to do it and make friends. So what I see the opportunity is so there's certainly the education piece. We can give people lots of facts that way. And we can also support what they're doing after they're doing it and build communities that connect people. But it feels like there's a piece in the middle where we have to actually be together, and the human component of helping people move through activities that are complicated that just requires other people is my best guess. So I think it's the placement, the sequencing of where web goes.
This is another good opportunity for your public library. One of our sites held a series where people came to the library and viewed, I'm not sure if it was a webinar or video, but it was on brain health. And then they had a large audience, well, for a small town, a large audience, and then they had somebody from the community there to answer questions and things like that. So, most public libraries have access to this technology, and at least in our state, they're really wanting to share it with other members of the community and have it used and be seen where the library is seen as a community anchor, a place where people come for information.
So thanks very much. We're really close to out of time, so one more very quick question, Rima.
Okay, very quick. Maybe the answer will be longer, though. We all know about the importance of documentation and measurement, and measurement on all those different levels of community, of within and among institutions, professionals, individuals, and so forth. I would love you to speak briefly, albeit, to the tension between the need to measure, especially baseline data, the need to measure and document, and the pressures to take action. And needless to say, I'm awed and really appreciative of all your fine work and your fine actions. but I wonder if you could just reveal something about that ongoing pressure.
Can I just make mention that just to acquire, like sending out a survey and asking an entity to help just respond to the questions, that in itself, if you're sending it out, like the Southwest Regional Health Equity Council, which I'm the chair of right now, we're getting ready to send a survey out to our state health departments in our region just to ask how they've been addressing health literacy in those health departments. And we know that a stumbling block is having that survey go to the right person to actually have it completed, and it may have to go to multiple people, or you know, again, because with agencies being as large as they are, some are smaller, so it may not be as difficult, but there are different people that can answer that question probably better than others. But it also requires that organization to come together, maybe a few people, to discuss those questions. That's where knowing who the champions of certain organizations are is helpful, so that we can expedite getting it to the right person, so that it can get completed and can provide information to efforts such as ours that are outside of a public entity or a private entity.
So, you know, I think there's always tension in this. Nobody likes to fill out the forms any more than they like to go to the gym. So all these things are hard. We can give them the forms. We make them as simple as we possibly can. But the other piece of it is having somebody on the backside looking to make sure they come in correctly and reinforcing the fidelity to start. And that's been really our struggle, is putting those systems in place to make sure we get the data, we look at the data, it's actually complete, it works. And there's a real tension there. Nobody wants to pay for that. It's expensive and complicated, but I think you said earlier, if you have bad data to start, can't fix it. So it's a constant tension, and nobody wants to do it, but I agree, must be done.
We actually do not have the tensions, because we were able to create a partnership with the Head Start grantees. They know that we're giving them the tools to be able to succeed, but as part of the contract, they know that they need to provide the data that we then analyze and share with them. So it's a give and take on both sides. We're there for them if they have barriers, but they know that this is part of their responsibility to provide both qualitative and quantitative, and they also see how we use it to make progress. So works for us.
So Rima, anybody involved in quality and performance improvement knows that tension. It exists, you know, like every day. But it shouldn't arrest innovation. And that's the tension. How to be sure that you're using data appropriately, and the data analytics help you move forward. But you have to kind of work that around innovative, and I think that's where the tension exists. So we'll continue that tension. Anyway, we do have a break now for lunch. For the roundtable members and speakers, the boardroom straight ahead will provide lunch. For others, on the lower floor, there is a cafeteria, and there's probably some limited availability in the community, but hopefully everybody will find their nutrition somewhere. And we'll be back at 1:15 for the next session. So thanks very much. This has been a very stimulating morning.